Hello, Montana, and hello, world. It's Chris Hislop from the Montana World Affairs Council, bringing you another episode of Connect Montana, where we bring the world to Montana and Montana to the world. This week, we're looking at healthcare systems, and we're going to be talking to two experts from Europe, Katrine Kirk from Denmark and Brian Fitzgerald from Ireland. Question: is healthcare twice the price at half the care, or half the care at twice the price, or twice the care at half the price? I'm not really too sure, but I'm glad that we have today with us Katrine Kirk, who is going to help us understand a little bit better and separate a bit the fact from the fiction on the provision of basic healthcare in Europe. Katrine Kirk has been a patient safety champion with WHO Patients for Patient Safety global program since 2007. This entails speaking at conferences, storytelling for medical professionals, facilitating workshops, and consulting on patient engagement. She is a representative on the Cancer-Related Complaints Board at the Danish Agency for Patient Complaints. Professionally, she has worked full-time on improvement projects in the Danish healthcare sector since 2008. Her work as patient engagement is as a primary focus, She has developed new methods for learning from the patient experience and has been heavily involved in numerous improvement projects concerned with making care more patient-centered. So, Katrine, we're so pleased that you could join us. Thank you so much for coming on. I wonder if we could ask you to start with laying out a little bit of the basics to help our audience understand a little bit better about the way in which the healthcare system works. Over to you.
Thank you. Thank you so much for inviting me, Chris. I'm honored to be here and really looking forward to also discussing with some of you when I conclude my little talk. What I'm going to do is I'm going to give you a personal account of my experience as a patient and a family member to patients. And then I'll provide also some context on the principles of our system and the economic side of it. And if it gets too long, please stop me. I will give you some context about how things work, but I'd like to start a little bit tongue-in-cheek somewhere else with the US preamble to the Declaration of Independence, which says, "We hold these truths to be self-evident, that all men are created equal, that they are endowed by their Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. And I've always found these words really moving. They do ring so true, at least if we can interpret men to be mankind and therefore also women, then I'm all aboard on that. But these values are surprisingly, perhaps, also very much in line with the way I think of our system. So what I'm going to do is I'm going to try to talk about the Danish healthcare system kind of through the lens of these concepts in the preamble. So equality, life, liberty, and happiness. I hope this will make sense. So let's start out with equality. The population of Denmark is about 5.8 million. And one of the fundamental aspects of equality in Denmark is equal access to healthcare, to education, and to other common goods. Healthcare and education are almost exclusively paid by taxpayers. So the government is in control of how we organize healthcare and education. So access to the highly specialized healthcare and to ongoing healthcare is almost exclusively public, and it is only based on the individual's needs, not on your ability to pay or whether or not you're employed. There is admittedly a small private sector that does, say, elective surgery for cosmetic plastic surgery, or knee operation, that sort of thing, which will allow you to access faster if you pay yourself. But it's a small percentage of our total healthcare system. Doctors and nurses in hospitals, they are government employees. The hospitals are owned and run by regional government bodies. Home care for the elderly is organized locally in the municipalities. So the nurses, typically nurses and nurses' aides and physical therapists, etc., they're employed by the local community. The GPs and the specialists, like if you want to see an ENT or a pediatrician, they are typically small businesses. They run their own business and they have some leeway in how they organize things. They are allowed to and encouraged to make money. And there is a difference between how much they make depending on how much they work and how well organized they are. But the payment for their services is also run through a standardized system and is also tax funded. So this payment structure is not visible to the patient. You're never ever presented with a bill for these services. So I think that speaks to the way we think about equality in Denmark. Chris, if you need to just, interrupt or bring in a question or whatever, but unless you interrupt me, I'll just continue. Okay. So the right to live, which is also mentioned in the Declaration of Independence, is not just about protecting people from murder here. It's also the right to be supported to a long and well-lived life. And in keeping with our modern day and age, that entails a right to high quality healthcare at all stages of life. And I was looking at life expectancy statistics and found that it's, interestingly enough, it's almost the same in the States and in the US, about 75 years for men and about 80 years for women. But in other types of healthcare outcomes, we do see significant differences. And this is where I'd like to sort of just talk about what it's like to be a patient in the Danish system. So many years ago, I was suddenly bothered by swelling of my neck, and I went to see my general practitioner. She took a look, she felt, she couldn't find it, she listened to me. She did a quick clinical sort of examination of me, and she couldn't find anything wrong other than this slight swelling. So she sent me home and said, come back in a week if it doesn't resolve itself. And it didn't. And eventually my neck swelled up so that I was very puffy from my jawline and right down to my collarbone. And when she saw me again, she immediately sent me to another sort of little specialist, an X-ray surgeon. No, sorry, X-ray specialist. This is a long time ago, so it was before CTs were sort of widely used here. And that image did show a sort of some kind of a shadow in my chest cavity between my lungs. So the very same day, my GP had me referred to a highly specialized hospital. And there it unfortunately turned out that I had a very aggressive type of blood cancer, so-called T-cell lymphoblastic lymphoma. And the only way to be cured of that would be to go through some quite extensive chemotherapy and then follow up with radiotherapy. During the whole time that I was in treatment, I saw the same hematologist at almost every appointment. I had a number of complications, blood poisonings, due to the low immune response during chemotherapy. And every time I was admitted straight into hospital, and they very quickly were able to get the infection under control. I felt quite safe and well cared for during this whole time. Unfortunately, after I was well again and I went back to work, I relapsed and I had to go through a much more intensive chemotherapy regimen. And the only way I could have a chance of surviving would be if I could have a bone marrow transplant. And even so, the chance of surviving was only in the 5 to 10% range. So at this time, I became quite desperate to really understand how can I increase my odds. And I looked into all the research about, what is the difference between patients who survive and who don't survive this illness. And that meant also looking at and taking contact to several American hospitals and a British one. I even went to visit the British one to figure out, was it, if my chances would be significantly better overseas, I would be willing to take out a huge mortgage on our home and then pay for it myself. But I became convinced that I would get gold standard treatment in Denmark, and went through with it, and here I am. So I'm very grateful to our system for that. But a few years later, my mother had metastatic breast cancer. And after a while, it became clear that it couldn't be treated. She couldn't be cured. So as her life sort of approached the end, she had some decisions to make, and she wanted to stay at home, die at home. And we were hooked up with like a home hospice care, which meant that there was a specialized palliative doctor who came to our house along with a palliative nurse and sort of explained things to us and evaluated her and had a treatment plan for dealing with her pain and other complications. They came to see her once a week, and they would also come if we called them for any special, with any special questions or anything. Alongside that, we also had home care provided by the local community. And this consists of a nurse who would come regularly once a day, plus nurses' aides that came 3 times a day. So we had 4 visits every day, and they took care of all her personal needs like hygiene, bed, getting washed, and all the really sort of personal and intimate things. And that freed up the time for me and for my father to just be her family. So we had a hospital bed installed in their dining room, overlooking the garden, and we would actually sort of cook fairly elaborate meals, and we would invite people over. And during the last few months that she lived, we had this really calm, extremely safe feeling around the whole situation. And she got to see her friends and family numerous times, because they'd come and they'd share a meal with us right there in the room where she was, and sometimes she'd doze off. Also, during this time, I took off, I went down from working full-time to half-time, and I was compensated by the government for the income loss that was associated with that. And even though my father was in a very high income bracket, he also did the same and was also compensated. So part of the egalitarian tax system is also that we pay into it according to our means, but we also receive some remuneration when things go wrong, even if we're in well-to-do brackets. I'm not sure how I'm doing for time here, Chris, but
maybe a couple more minutes, Katrina.
Okay. So sometimes socialized medicine is criticized for taking away people's freedom. And that is, of course, another part of your constitution that's very important. Freedom of choice in selecting doctors, choosing between insurance plans, and deciding which treatments to opt for. And I've even heard talk of that we supposedly have death panels in Scandinavia that decide, who can have and who cannot have life-extending care. It really, it just boggles the mind to me what exactly, how that myth has arisen. Because the thing is, coverage is prioritized everywhere in the world. Here we have scientific committees within each medical specialty, and they look at treatments and medicines and evaluate costs against benefits. And I've never heard of anybody being denied a treatment that has scientific evidence for its efficacy. I really haven't. And right now, there's a debate, a public debate going on about an 18-year-old girl who is going to be blind by the time she's 30 due to a rare disease in her eyes. And there is a treatment that may or may not help her, most likely may not help her. But it costs 5 million kroners, that is like 700,000, it's more than $700,000. And we're debating whether or not to provide that free of charge for her. So that's kind of the level that we're at in terms of prioritizing. What happens in the insurance plans that you have is that it's not transparent, you know, how are they prioritizing? I've known, because I've been active in online support groups, I've known patients who have been denied care that could potentially have saved their lives. So I think this is a challenge in all, you know, in all countries, this, how do we prioritize care? Finally, on happiness. Well, Denmark, Norway, Sweden, and Iceland come out, and Finland always come out in the top 10 of these countries of the world. Whereas in the latest ranking, the US was 19th. And although, you know, although it's never a happy thing to need healthcare, I would say that it certainly removes a lot of stress, never, ever, ever to have to worry about whether you can afford necessary medical care. It's just one more thing that we don't have to deal with, just because I was never presented with a bill for any of this hugely costly treatment that I've been through. And I've left out I've left out the tax system. I think many of you might think that you'd be very unhappy paying the taxes that we do. And I had a look at the Danish Census Bureau, and it turns out that as a flat rate, total personal income for the whole country and total personal taxes for the whole country, we end up that we as a country are paying 32% in total personal taxes. And of course, there's a huge difference between how much we pay if we're in the high income brackets or the low. And for someone I know who is in the top 2% of the Danish income bracket, his sort of flat rate total tax payment is 49%, but that's unusually high. For someone who is well educated with a master's degree, someone like me, for instance, I think I end up at around 40% on the total. But then if you look at your taxes and then add on the total health insurance that you pay, plus the total health care costs that you pay, plus all the total costs of putting your children through school, college, and not just tuition, also supporting them once they're in college, because we don't do that here either. The young people here, when they go to college, they're independent. They don't rely on parents' incomes anymore. If you add all of that up over a lifetime and then divvy it out, I'm sure you'd be surprised at how high your own tax rate would be. Okay, I'll shut up now.
Katrine, thank you so much. I mean, where else do you start with the U.S. Constitution, go through an entire system, have some happiness, and then end up on taxes? So we're covering a huge amount of ground for our. I would like to kick off the questions if I could, Katrine. We've got a few minutes here for. Which is to go back to the starting. You talked about the Constitution here in the United States, which, as you know, is open to interpretation. And that's what we do. We interpret the Constitution for our own laws. Now, I would like to know what, from a Danish perspective and from your very interesting patient-focused perspective, on an interpretation, what is the interpretation of good care for somebody in the Danish system? Because in America, I would say broadly speaking, what a patient is going in, what are their metrics or their interpretation of what they get? Number one, did I get healed or am I better? You know, number two, how was the quality of care? Was it adequate? And number three, what was the cost? So I would interpret these three metrics to be important here in America to patients. What does it look like from a Danish perspective?
Well, I think it's pretty much the same, but we just don't worry about costs because we have a system that takes care of that. We do look at, do we feel better? That is, of course, the most important thing. But there is a subtle difference. I was just discussing it with an American friend on the phone today. She's moved temporarily to Denmark and has had an occasion to visit a doctor twice while she was here. And she says, well, she left the GP's office twice, once for her son and once for herself, without a prescription. And she thought that was odd because she was always given a prescription in the States. It's like, and we talked about, how she feels that they're very customer centered in the States. And I realized that we're not customer centered here at all. We're patient centered. And what that means is that the doctor does not have a financial incentive to sell you anything here. No diagnostics, no tests, no. So it's all based on the scientific evidence of what will actually help the patient in this situation. And there's a tendency to probably do a little bit more watch and wait here. Like the first time I saw my GP, my neck was swollen, but she sent me home and said, keep an eye on it and come back if it gets worse. Whereas I think in the States, that might feel like I'm not being cared for. I don't know, but I'll put that question out there.
Very interesting. Let me just encourage any of our guests also to please chat in a question to Katrine if you have one. But I have another one, Katrine. You mentioned it very briefly, but if you wouldn't mind kind of digging a little bit deeper. Another complaint or issue that we often throw at the European or other socialized or national healthcare systems is wait times for specialty treatment. Now, it is a fact that there are per capita fewer specialists, medical specialists in specialized fields in Europe in national systems, but I'm not sure if that translates necessarily into longer wait times. What does it mean from a Danish perspective in terms of waiting for adequate and quality specialized care?
We have we have a system here that if you are suspect of cancer, so your GP sees symptoms and says this just might be cancer, then there is a guarantee that you will be diagnosed. You will start diagnosis in a hospital within 2 days. If there is a suspicion of something else that is serious that needs a further diagnosis, then the wait times are pretty short. Of course, with acute care, like if you have a heart attack or whatever, the ambulances will be there within 10 minutes. I think it's a maximum 10 minutes everywhere in the country. If it's, let's say, back pain or arthritis of the knee and you're considering an operation, the wait times can be longer than we'd like, admittedly. You could be waiting for, say, 2 months or 3 months even. But if it's acute, if you're debilitated, then typically, they move you up the line. So it's hard to say in a very general sense, but I think we do have our heads on straight about taking care of those who really need care urgently.
We've got time for one last question, Katarina, if you're okay, coming in from one of our participants. You mentioned a number of very interesting, like a comparison of costs, but in terms of total amount or total percentage of taxes paid and their use. I wonder if in there, maybe you said it already, but I'm going to come one more time. Is it cheaper at the end of the day to provide a kind of healthcare for all, as you described, versus, the American system, which requires insurance. Now, if you're not insured, you can still receive care, but the cost of that care then comes back to us, of course, in taxes. If you're
Mhm.
not insured and
Mhm.
receiving care, it's not free. It still ends up costing, and somebody's got to pay. And typically,
Mhm.
that, of course, is the taxpayer. So, in your
Mhm.
own research, can you make a comment on kind of overall? Is it cheaper, more expensive? Is it a wash?
It's definitely cheaper here. The total healthcare spending per capita in the US is $11,071 per year per person on average. In Denmark, it is 5,567 US dollars per capita per year. Um, but what actually makes it cheaper is that the whole administrative stuff around it is a lot less expensive. I mean, you have so much management and so many sort of accountants and billing systems, and that whole sort of the whole management of who pays for what in the minutest detail is very, very costly. Also, and this probably doesn't count as a healthcare cost, but I think that your whole sort of malpractice suit and the whole sort of lawyering up of medicine in the States, that must be exorbitantly expensive also. So on the whole, I think because our system is just simply it's so much simpler, there are many costs that don't get incurred. And also there's another factor, and that is we tend, as I kind of talked about, we tend to not treat as aggressively as they do in the States. We don't have nearly as much diagnostics. We don't hospitalize as much just to be on the safe side, etc.
Mhm. Well, Katerina, a great way to wrap things up, and thank you very much for hitting, I think, what were, really the prime questions that come from an American audience vis-a-vis a European, in this case, the Danish system. So over to you, 30 seconds or less, if you have any last comments for us.
I think it's wonderful that you're all exploring this, and I just hope you don't let yourself be scared off by some of the myths that abound about socialized medicine. I hate the word socialized medicine. We're not a socialist country. We have huge companies like Lego and Maersk and Novo Nordisk, which you might know. But and it's a market economy. We just have democratic medicine. We have a system that is open to public scrutiny, and that works. So don't be afraid to explore it, and think about that when you vote.
Democratic medicine. That's an interesting way to put it, Katerina. And thank you very much for lending us your perspective and your views. Really appreciate it. And thanks to the audience for joining us. A reminder, on Thursday, same time, 12 noon Mountain Time, we have Mr. Brian Fitzgerald, who's the Deputy CEO of the Beacon Hospital in Dublin, Ireland. He comes with a wealth of knowledge across the board on the European system and a really in-depth systematic view. So if you're really interested in getting another perspective and on other elements of this healthcare provision, please join us on Thursday. Finally, like I always say, if you like this kind of thing, if you like to learn about the world and engage in these issues, please continue to join us. You can look over my shoulder here and see our website. Join us as a member. Why not? You can get in on all of these interesting things. And if that's not your thing, share this with your friends. We have programs like this all the time. We've got several weeks of Connect Montana coming up. Next week will be International Peace Week. After that, we've got misinformation, disinformation, and fake news, followed by international election monitoring. So an incredible array and interesting things coming up. So thank you all for joining us. Thanks again to Katrine Kirk for joining us. We really appreciate it. So until Thursday, everybody, thanks again. Bye-bye.